I'm going to introduce our next speaker. His name is Dr. Joseph Ricotta. He's a vascular surgeon and also specializes in endovascular therapy. Dr. Ricotta did his residency at Oxford University in England and Johns Hopkins School of Medicine in Baltimore, and his fellowship at the Mayo Clinic in Minnesota and the Cleveland Clinic in Cleveland. So without any further ado, Dr. Joseph Ricotta.
So who knows what peripheral artery disease is? Let me see your hands. Not too many people. How about venous insufficiency? Okay, all right. All right, well, very good. So in about 20 minutes, I'm going to ask those questions again. I expect everybody to raise their hand, okay? All right. So first, we're going to talk about peripheral artery disease, or otherwise known as PAD, okay? And that's when you have blockages in your arteries in your legs, usually with cholesterol plaque. So much like what was discussed previously, where you can have blockage in your heart arteries, you can also have blockage in your leg arteries. About 12 million people in the United States have peripheral artery disease. So it's a pretty big issue for our healthcare system. And peripheral artery disease has a big spectrum. And on one side of the spectrum, you can get pain in your legs when you walk because your muscles aren't getting enough oxygen, because the blood carries the oxygen. And if you have a blockage in your artery, you're not getting enough blood flow to your muscles, you're not getting enough oxygen to your muscles, the muscles make acid, and it gives you cramps. So you get pain in your legs when you walk, that's called claudication. Or on the other side, you can have pain in your legs at rest, even when you're not walking, because the blood flow is so blocked. And you can have gangrene and sores on your feet, and that's what leads to amputations. So that's called critical limb ischemia. So there's a wide spectrum of peripheral artery disease. It usually affects people over the age of 65. 85% of amputations are done in people over the age of 60. 1 in 3 people over the age of 50 that has diabetes will have peripheral artery disease, so diabetes is a high risk factor. There's over 500,000 amputations done in the United States every year, and this is a big take-home point, okay? 500,000 amputations done every year. 50% of those patients never even have their blood flow looked at in their legs. So people are having legs and feet and toes amputated, and nobody's even looking at their blood flow to see if we could correct it to try to save those body parts. And of all amputations, 60% are done with people with diabetes. In terms of mortality rate, so PAD has a high mortality rate, okay? In 5 years, 30% of people in 5 years with PAD will die. People with critical limb ischemia, which is the other side of the spectrum with ulcers and sores and gangrene, almost 70% of those patients will not be alive in 5 years. So PAD is a bigger killer than a heart attack, acute myocardial infarction, colon cancer, breast cancer, and even stroke and prostate cancer. It's a bigger killer than all of those things. Despite that, unfortunately, the awareness is very low, and that was borne out by when I asked you guys how many people know what it is. So this is a survey that was done of 2,500 people that asked them, do you guys know what PAD is? And only about 25% said yes. That's less people than Lou Gehrig's disease, multiple sclerosis, and certainly heart disease and stroke. So even though PAD is a bigger killer than all those things listed there, the awareness is very poor. Not only in the community, but also with healthcare providers, in my opinion. So we need to do a better job about making people aware of PAD in the community and also in the healthcare field. The main risk factors for PAD is high blood pressure, smoking, big risk factor. It only takes about 100 cigarettes to do the damage, so it doesn't take a lot. So even if you're a former smoker and you smoked for a few years and then quit, you can still do damage to your arteries. It's better that you quit than you're not keep smoking, but you can still do damage to your arteries. Diabetes, again, and high cholesterol. So probably much of what you heard in the previous talk. The original way to treat it is with surgical bypass, okay? Where we have to basically make incisions in the whole leg, and we have to sew a bypass graft, usually a vein, from above the blockage to below the blockage. Big incisions, 2, 3, 4, 5 days in the hospital, 3-month recovery time, okay? And one of the nice things about vascular surgery is over the last 10 or 15 years, we've made this transition from doing big open operations to endovascular procedures where instead of doing that big bypass, we can just do a little puncture in the groin and we can fix everything from the inside. So endovascular is called, it means inside, inside the vessel, endovascular. So just through a puncture in the groin, we can fix everything instead of having to make a big cut in the leg. In 1999, at the turn of the century, 100% of the PAD cases were being treated with surgical bypass. And the amputation rate was about 30%. And then over the next decade or so, more in green here, these numbers aren't showing up that well, but in green is endovascular. More endovascular cases, about 90%, and only 10% bypass. And probably in 2017, this green bar is about 95%. But you can see what happens as we did more endovascular procedures, the amputation rate went from 30 to 5. And that's because when we do things from the inside, not only is it easier for the patient, less invasive, but we can get down into these tiny little arteries in the legs and the ankles and the feet and open those up that you could never do a bypass to. And I'm going to show you some cases that demonstrate that. And this is another big advancement we've had in vascular surgery. So this is called a hybrid operating room, and this is what we use. And that, not the Magellan yet. The next picture is the Magellan. So you must have had a preview of my talk before I got here. So the hybrid operating room allows you to do procedures like you would do in a cath lab, endovascular procedures, but also surgery in one place. So the patient can be treated with anything that we need to treat them with, surgery or endovascular procedures in one place, one-stop shop. They don't need to come back another day, go to another part of the hospital. We can do everything in one place. And then the Magellan robot is the next thing, and in my practice, this has been a big advancement. And just like you probably have heard of the Da Vinci robot, the surgical robot, where you can control things through a workstation, from a remote workstation, the Magellan robot is an endovascular robot. So this is the robotic arm, and you put the wire into the patient, and then this is the robotic catheter. And then the patient is here, and I'm sitting at a workstation remotely, and with these buttons and knobs, I can control and manipulate the catheters and the wires inside the blood vessel and navigate through those. And it allows you to be very precise with what you do. And it simplifies complex procedures that otherwise, when you're doing it manually with your hands, might be a little bit more difficult, or you can't do it manually with your hands. This robot allows you to do it, and I'll show you some cases. And this is just this is just the control that you have with the robot. So with these little buttons and knobs, we can have one catheter, and I can bend it however I want. I can rotate it 360 degrees. I can make it into any shape that I want. And so when people have angles and twists and turns in their blood vessels, I'm able to, and even blockages, I'm able to get through them pretty easily with the robot, whereas if I was doing them with catheters, it'd be a little more challenging. The other thing that's very important with the robot is when you're doing them with catheters, sometimes the catheters can scrape against the inside of the wall of the artery, and it can knock off some plaque, or it can make a little flap in the artery. This robot is very precise, and it stays in the middle of the artery, and you don't have what we call vessel wall trauma. You're not scraping the wall of the artery, so it's very precise. And this is just also another picture of the robot. You can do things in a two-dimensional and also in a three-dimensional view. So I can see inside the blood vessel in 3 dimensions and navigate through there. And this is a picture of the robot mounted on the table. So the patient would lay here, and we put the wire into the patient through that puncture in the groin and hook it up to the robot, and then I would work at that workstation. And you know, when I was in Atlanta, we did the first case in the southeastern United States a couple of years ago, and then when I came to South Florida 3 months ago, we were fortunate enough to do the first case from Broward County all the way to the Florida-Georgia line. In the state of Florida in early November, we did the first Magellan robotic case, and this is the picture of it. Here's the patient here, and we're working with the wires and the catheters on this monitor here. So there's a lot of tools that we have at our disposal to do things endovascularly, and I'm going to just go over a few cases with you. The stents, we have new stents now that don't kink, so when you put them across the knee joint, they're very resistant to kinking and flexible. They're like, this is like a slinky stent, and you can bend it and twist it however you want. It's not going to bend. So when you're walking and you're bending your knee, that stent won't kink. The previous stents would kink. I do a lot of what's called atherectomy. So when you have plaque in an artery and you balloon it, sometimes you're basically ballooning that plaque up against the wall. You're sort of smashing the plaque against the wall, and then you put a stent through there to keep a channel through there. As a surgeon, when I operate on arteries, I take the plaque out. We do what's called an endarterectomy, and we clean out the artery. You can do that endovascularly with with this atherectomy device. And what it does is you put a wire through the plaque, and this specific one is a sanding device. And you can put it through and you run it back and forth and it rotates and it's got a sanding blade on it. And you can basically sand away the plaque, and it sands it away into such little tiny particles that it just gets washed away in the bloodstream. So you don't have to worry about it going and plugging up anything. And so basically you can do the same thing that I would have to do surgically, where I have to make a cut and cut open the artery and clean out the plaque. I can do this endovascularly from the inside. I can clean the whole artery out from the inside with this device, and then I can balloon or stent or whatever I need to do. But the important part is to get rid of the disease, and so we can do that all through a little puncture. And there's also things that we use to get through blockages. This is a laser catheter, and basically uses laser energy to vaporize the blockage. And so when you get through a blockage in an artery, we can use this laser to help vaporize it and get through and remove it, and then we can do ballooning and stenting. So there's a lot of different tools and new technology that's out there that we use to help us get rid of plaque and get through the plaque. Drug-coated balloons also very important. So after I've gotten rid of the plaque, then I usually put a balloon up that's mounted with some medication. And when you blow the balloon up, the medication gets leached out into the artery. It gets leached out into the artery, and it prevents the blockage from coming back. So it's a special medicated balloon that we use. And we were the first ones to do this in the United States in 2014 when I was in Atlanta. So I'm going to show you some cases using the hybrid operating room and using the robot. This is a case that we published, but this is all this white stuff, if you can see that, is plaque in the femoral artery, in the groin artery. Normally we would make an incision in the leg, open up the artery, and scoop out the plaque. Here, this patient was not healthy enough to have an operation. So what we did is we came through a little puncture in the wrist, and we came up from above and came down through here, and we used that sanding device, and we ran it through once, and you can see that white stuff is going away. And we ran it through again, and you can see there's hardly anything. And then we did the ballooning with the drug-coated balloon, and you can see here it's gone. So we got rid of the plaque. We got rid of the plaque from the inside. This patient went home 2 hours after the procedure and went back to their normal lifestyle the next day. So instead of having an operation for 2-3 hours under general anesthesia and staying in the hospital for a couple of days and having 3 months of recovery time, this took about 45 minutes to an hour, and they went home 2 hours later, and they went back to their normal life the next day. You're treating it from the inside. This is another case. This is somebody's aorta, and they have no blood flow to their right leg. This is their left iliac artery, the right iliac artery, no blood flow to the right leg. Normally, this would require a big operation where we open up the belly and we do an aortofemoral bypass. We were able to come from the arm again and get through there and do the sanding and then doing ballooning and stenting. Again, patient goes home after a couple hours. We fixed everything from the inside. They go back to their normal life the next day. This is a patient, again, this is one of those pre-lunch pictures for you. So this is a patient that they were sent for amputation. So this is somebody with, on the far end of the spectrum, the critical limb ischemia spectrum. This is one of the 550,000 people that would be sent for amputation. We looked at their blood vessels. We saw that this was a blockage in the groin artery. The whole thigh artery is blocked. And we were able to get through that using our techniques, using the robot. This is actually the first robotic case I did when I was in Atlanta, the first case that was done in the Southeast United States. We were able to get through there. And there you can see the before, and then you can see the after picture. And then you can see how the foot healed. So we were able to prevent an amputation in this patient and heal this patient's wound and save their leg. All endovascular. This is another case of infected ulcers. Again, these are all squiggly lines. There's no good blood flow going down to the foot. This patient was, again, sent for an amputation. A couple other people tried to open up these blockages, couldn't do it. They were sent to us. We opened everything up and healed the patient's foot and saved their leg. So this is a pretty ugly foot. This is another patient that was sent for an amputation. That looks pretty bad. And a couple doctors had done angiograms and said, unfortunately, there's nothing to do. And the reason they said that is because here's the angiogram. This is the thigh. This is the knee joint here. The blood stops in the thigh, above the knee. Here's the leg. There's no real blood flow to the leg. And here's the foot. This is the heel. This is the toe. There's some screws in the ankle. There's no blood flow into the foot. So even if you wanted to do a surgical bypass to this patient and do a bypass from the groin to the foot, Where are you going to do the bypass to? There's no artery to plug into. There's no place to do a bypass. So we were able to do it endovascularly. There's the before and there's the after. We reconstructed the popliteal artery. We reconstructed the tibial arteries, and we got the flow back into the foot, and that foot that you saw was saved. So that's the advantage of endovascular. It's the advantage of endovascular robotics. We can get down from the head to the toe, literally the toe, these tiny little 1 millimeter vessels that you could never get to surgically. So for PAD, I'm going to talk about venous disease for 5 minutes because I know we're on a time crunch. But for PAD, it's associated with significant mortality and amputation risk, but unfortunately the awareness is low. So we need to improve the awareness in the community and also in the healthcare field. Anybody that has a wound on their foot or is scheduled for an amputation needs an angiogram or some study to look at their blood flow, because lots of times we can help save the leg by improving the blood flow. And most of the time the endovascular technique is the most successful thing to do. I'm going to talk to you quickly about venous insufficiency. The arteries take the blood from the feet to the heart. The veins take the blood back up from the heart to the feet, okay? So veins and arteries are different. So we're now talking about return of blood from the feet to the heart. And you can get varicose veins, you can get skin changes, you can get ulcers with venous insufficiency. This is another issue, and not a lot of people raised their hand when I asked them if they knew what venous insufficiency was. 30 million people in the United States have venous insufficiency. Less than 2 million people get diagnosed and treated with it because the awareness is low. They think it's old age, they think it's cosmetic, they think it's, their medications, and so doctors put them on water pills because they have swollen legs, and it must be, from retaining water, but it's from this problem. It's more common than heart disease, by twice as more common, and 5 times more common than PAD, what we just talked about. Sorry. The female gender, more commonly affected. Once you get over 40, are more commonly affected. People that have family history of varicose veins, leg swelling, vein problems, smoking again, women who've been pregnant, especially multiple pregnancies, obesity, and then people that do things for a living that makes them stand a long time, like a teacher or a vascular surgeon or other things that make you stand up for a long time because the veins are trying to push up and gravity is working down against the veins. And it can cause anything from spider veins and varicose veins, the bulging veins, to leg swelling, to discoloration of the legs, to even ulcers. But heaviness and tiredness, a feeling of weighted down of your legs, like people say my legs feel like a ton of bricks, usually at the end of the day because, again, gravity's been working on your veins all day. Burning or itching, aching, discomfort, cramping, and even restless leg syndrome can be caused by this problem. And this is the mechanism. So the veins, again, take the blood from the feet to the heart. And it's a one-way system up. And as the blood goes through, the valves are supposed to close to keep it a one-way system up. When the valve doesn't work well, the blood falls back the wrong way, and it pools in your legs. And that's what venous insufficiency means, because the valves are insufficient. It's also called venous reflux, because the blood's refluxing down the wrong way. So that's the problem. It's with these leaky valves here. You have leaky valves in your veins. So the way to diagnose it is just with an ultrasound in the office. Very simple. We can do it in our office quickly in about 30 minutes and look at all the veins and see if you have leaky valves. Once you're diagnosed with it, there's different types of treatments. I don't know if anybody can read this, but it says, don't you think you're taking this elevate your legs thing a bit too far? So elevating your legs and wearing compression stockings is good. I have compression stockings on right now, but it doesn't fix anything. It'll help push the blood back up to the heart, but it doesn't fix anything. When you don't wear the stockings, everything comes back to the way it was. So the way to fix it is really to take that bad vein out of the equation somehow. Again, the sort of the old-fashioned way is to do vein stripping. I don't know if anybody's heard of vein stripping, but this is what it looks like. You have to do it under general anesthesia. You make a big cut in the leg, and you pull the bad vein out. Afterwards, you got a lot of bruising, pain. You have to stay overnight, at least one night in the hospital. We don't do this. I don't do this procedure anymore. Now we can do everything from the inside. It can all be done in the office in a room like this in about 15, 20 minutes, and you walk out. Easier than going to the dentist. And again, it's fixing it from the inside. So the way you do it is under ultrasound, you put a little wire into the vein. This is the vein under ultrasound. That white line is the wire. We put a catheter into the vein. And instead of taking the vein out of the body, you can close the vein down. You leave it in the body, but you shut it down. So no blood falls down through the wrong way. It serves the same purpose as actually taking the vein out of the body, but it's much easier more easily tolerated by the patient. All the good veins take over. And you can close it down with heat, which is this radiofrequency ablation, it's called, heat, where you have the catheter in there and you basically heat close or cauterize that vein closed so no blood falls the wrong way. Or you can close it with super glue, which I'm going to show you about in a second. But you think I'm joking, but I'm not. So here's just a picture in the office with a little IV in the vein in the calf. This is the knee, this is the foot. We put the catheter up, that's what it looks like under ultrasound. And here's a before and after. Hopefully you can see the results. This is 1 week after treatment. All these bulging veins went away. And more importantly, the symptoms of heaviness, tiredness, achiness, swelling, burning, itching, restlessness, they all go away. Again, it takes about 15 minutes to do. You walk out of the office with a wrap on. The super glue is this. It's called Venous Seal. And this is a new technology. In Atlanta, we did the first case in the Southeast United States about a year ago. We did the first case in Florida about 3 months ago when I got here. And basically, this is how it works. So you go in through the vein. Can you shut that for me? You go in through the vein and with ultrasound, and you put a wire up, and then you put the catheter up, and you do everything under ultrasound. Then we press down with the probe, and you basically inject this adhesive polymer, this Venous Seal. It's a polymer. It's basically super glue. It's cyanoacrylate is the name. And you press down, and you basically glue the vein shut. So you don't cauterize or heat the vein shut, but you glue the vein shut. This glue's been around since the 1950s. We use it for brain aneurysms and AV malformations and aortic aneurysms. It's new for the veins. And so basically, you walk this out, you inject, and you walk this catheter out until the whole vein is glued shut. Again, all this is done through just a little needle stick in the calf. You don't have to give any numbing shots. With the heat, you have to give numbing shots because when you turn the heat on, you don't want the patients to feel it. This has no numbing shots because you're not going to feel anything because there's no heat. So no numbing shots with the glue. Afterwards, as I said, in the calf, you just take it out and you put a little Band-Aid and you're done. The advantage of the glue over the heat is, again, no numbing shots, no risk of injury from heating because sometimes you can have nerve injury from heating. With the heat, you have to wear stockings or wraps for 2 weeks and you can't exercise for 2 weeks. With the glue, you don't have to wear anything, just that Band-Aid you saw, and you can exercise the same day. We had a guy that we did just the other day that he's a lawyer. He did it on his lunch break. He went back to work, and then I think he trains for triathlons, and he trained that night. No problem to go back. And so you can. There's no recovery time. You can go back instantaneously. And then with the heat, if you have it on both legs, you have to do one leg at a time. With the glue, we can do all the legs at once. So those are the advantages of the glue. But here are just some pictures of some cases, and we're almost done. This is a 50-year-old who didn't want to take time off from exercising and working out. And you can see, hopefully you can see these big veins that he has here. 1 month later and 3 months later, they go away. And again, not only cosmetically does it make a difference, but also from a symptomatic standpoint, the symptoms go away. It's another school teacher who couldn't take time off and didn't want to wear stockings. And you can see the before and after. And this is a fitness instructor, again, didn't want to wear stockings, wanted to keep exercising. You can see the before and afters. And here's a before and after, and another before and after. So that's what I have for you. So how many people know what peripheral artery disease is? Not everybody raised their hand. I didn't do my job. How many people know what venous insufficiency is? All right. So thanks very much for your attention. I'd be happy to answer any questions if you have them.